Hello, everybody. Good afternoon. It is so great to see you here today. My name is Rebecca Andrade, and I'm the Educational Programs Manager here at the Kansas Health Institute. And I would like to welcome you to the first session of the 2025 KHI Policy Learning Series, Exploring Medicaid in Kansas. Today's session will focus on exploring how KanCare addresses health-related social needs. Before we get started, I'm just going to go over a few details with you for today's program. So a little bit about who we are. KHI, or the Kansas Health Institute, is a nonprofit, nonpartisan educational organization based in Topeka. We were established in 1995 with a multi-year grant from the Kansas Health Foundation. And we are guided by the vision that Kansas will become the healthiest place to live through evidence-based and innovative strategies, policies, and practices. We work towards this vision by providing nonpartisan information, convening crucial conversations, and facilitating learning that leads to meaningful change. If you visit our website or our building, you'll see that our work involves research, evaluation, technical assistance, and policy analysis, as well as podcasts, blogs, and gatherings, just like today's convening. And so now it is my pleasure to introduce Carrie Bruffett, our President and CEO, who will help us launch the series.
Hey, thank you, Rebecca. And yes, I join Rebecca in welcoming everyone. Looks like we've got about 90 folks so far. We're excited about today's conversation. A reminder, as Rebecca says, that this kicks off the first of a quarterly series titled Exploring Medicaid in Kansas. Some of you may have been with us in October when we had a session that was also called Exploring Medicaid in Kansas, where you all helped us identify topics and themes for each of the sessions in 2025. So we'll in addition to our first topic today that I'm excited to hear more from a great group of panelists and my KHI colleagues in presenting, which is about how KanCare can address health-related social needs. We will, in June, be exploring KanCare and behavioral health certified community behavioral health clinics. In September, we'll be exploring maternal health in KanCare, including the impact of doulas and community health workers. And then in December, we'll be exploring how KanCare interacts with people who are experiencing homelessness, the unhoused in Kansas and in the KanCare program. So thank you for helping us design the curriculum for this year's series. And thank you to everybody who's going to participate, not just by sending us great questions that will really hopefully help us frame wonderful conversations with our panelists, but also think about future topics as well. I'll also let you know, and you'll get some information at the end of the convening, that we also have some very timely material that will be posted on a regular basis, tracking what's going on in Washington, D.C., some of the discussions about that might impact Medicaid. So look for a blog about that here very shortly with the Kansas Health Institute, and some continuing products that help us keep up to date on how federal policy might impact state policy in Medicaid, including in issues such as the one we're going to learn about today. But right now, it's my pleasure to introduce my colleague, Sheena Schmidt. Sheena is a senior analyst, and she's the strategy team leader for the Access to Care strategy here at KHI. Included in that strategy is a heavy focus on KanCare or Medicaid and the children's health insurance policy. So she and a number of her teammates put together the presentation today that will help kick us off and then really set the stage for what I think will be a very engaging and interesting panel discussion. As Rebecca said, feel free to use either the Q&A or the chat to ask questions or interact with each other. We really want this to be a conversation. So with that, I'll turn it over to Sheena.
Thank you, Carrie, and thank you for introducing everyone to the policy series. As Carrie mentioned, we're very excited to welcome all of you to the first iteration. And I did want to note that we're trying something new. So for individuals that attend, we're keeping track of attendance. We'll be reaching out to you, and you'll receive a special token of appreciation for attending all 4 series for the policy session. You'll be a Medicaid policy expert by the end, hopefully. So we really appreciate it, and would welcome and continue to welcome your active participation and engagement with not only us, but the panelists today as well. So yeah, let's get started. I wanted to go over a little bit about the agenda. So we are going to be presenting some information, an overview of KanCare and health-related social needs, how KanCare addresses it generally. Then we'll hear from panelists. We'll have an interactive conversation with several MCOs, both excuse me, I'm sorry, both United Healthcare and Healthy Blue are joining us today. Sunflower could not join us due to scheduling conflicts, but I know they did register and are welcome continue conversation and questions about the services they provide as well. Uh, then we're going to hear from community perspective. So, what services are provided, but in the community on the ground, like how are members experiencing those services that are provided to address health-related social needs. And then we'll just wrap up with closing remarks, any questions, and a preview of upcoming sessions and other Medicaid work by KHI. Here are our panelists for today. We're welcomed by Lucia Jones Herrera with United Healthcare Community Plan in Kansas, her colleague Stephanie Jurgensen, and also Thamara Submarinian with Healthy Blue Kansas, and Angela Scott, who is a community health worker, and she was a leader under Communities Organizing to Promote Equity, a COPE project that trained and assisted community health workers across the state of Kansas. So very thankful for their participation today, and I'll let them tell you a little bit more about themselves and their roles when we get to the panelist discussions. So, to get us started, we want to hear from you. You can be anywhere today. We want to know what brings you to today's session, what kind of sparked your interest, and if you'll just enter any thoughts and responses you have in the chat, we'll get us started, and you can start interacting with each other in the chat. While you're doing that, I will go ahead and start sharing some information about KanCare and how KanCare addresses health-related social needs. A little bit of background. KanCare has oversight from the Kansas Department of Health and Environment and the Kansas Department for Aging and Disability Services. They also closely collaborate with the Kansas Department of Children and Families because children in foster care are also included in Medicaid. The state of Kansas began contracting with managed care organizations for most Medicaid services in 2013 under the Brownback administration. And those managed care organizations are responsible for coordinating care of Medicaid members, including visits to primary care, specialty care, nursing facilities, hospital stays, behavioral health, and home and community-based services. And today we're going to hear about what they do and what they offer for health-related social needs. Developing a provider network that meets the needs of its members, paying providers for their services, and overall ensuring quality of care. So, a little bit about the new contracts that were awarded in January of 2025. They aim to implement several key improvements, and specifically addressing health-related social needs was a key component of the awards and the contracts that are in place now. So, more specifically, how does KanCare address health-related social needs? To level set a little bit, health-related social needs refer to the individual non-medical factors that impact health outcomes like housing or food, access, transportation. They are related to the social determinants of health, but social determinants of health are kind of like the environment and systems that are in place that influence our health overall. And then things like transportation, food, and housing are kind of like that individual level needs that are focused on. And that's what KanCare aims to address. So you may hear related terms like health-related social needs, social determinants of health, risk factors, those kinds of things. They all generally are aimed at those factors that influence our health kind of outside the medical office, but that definitely contribute to our overall health and well-being. And they're all related, and they are all definitely pointed out and included in Medicaid services, and it's definitely been intentional in this latest RFP process that resulted in the new contracts that were recently awarded and in place in January. So Medicaid enrollees have access to support like housing assistance, nutrition programs, and transportation to medical appointments. States and MCOs can use Medicaid flexibilities, which I'll go into detail a little bit later, to cover the services, to improve access to care and reduce disparities. And the services can address all of these factors in an effort to improve overall health and well-being of its residents, of its members, and by, in doing so, lower healthcare costs overall. All right. So some of those flexibilities that I just mentioned, federal rules do prohibit states from using Medicaid funds to pay for housing or food, but states can leverage existing authorities to support individuals with these needs. In doing so, in 2021, Centers for Medicare and Medicaid Services issued a letter to states describing how Medicaid agencies can utilize managed care authorities, and they can do so in several ways. So they can cover for specific social services under the state plan. They can use the Section 1115 demonstration waiver to provide services, or they can use value-based payment arrangements to finance interventions. And KanCare offers a variety and allows for these all three of these flexibilities. But it is important to note, and as Carrie mentioned before, we are tracking and monitoring decisions at the federal level and potential policy changes. And one, it's very timely for our discussion. As of March 4th, CMS actually rescinded the previous bulletins focused on how states can address health-related social needs from November 2023 and December 2024. And those bulletins were largely focused on which services could be provided and how. And so now, while they're reviewing those bulletins, CMS is now reviewing state proposals for any additions on a case-by-case basis. And I see a few questions coming in the chat. So if my team can help me and wants to pause and kind of pose a question as I'm going along, we can, or we can definitely address it following the presentation. So thinking about what's all included, I wanted to back and talk a little bit about the RFP process that KanCare underwent in order to develop the request for proposals and the requirements and the contracts that were just awarded in January that became effective. So January 1st. Uh, they went through a stakeholder input process, and also KHI was involved in facilitating conversations across the state with various organizations. And here are some recommendations that came out of those conversations that were hosted by the Reach Healthcare Foundation. They wanted to require MCO, or they recommended requiring MCOs to provide robust plans and support for transportation, childcare, and housing. They encourage investment from MCOs into Kansas communities. They also recommended formally integrating community health workers into the care team, and wanted to include data on services and outcomes, and specifically requested that that data be disaggregated. So several of those items were included in the KanCare RFP, and you can see them in the contracts, and we'll go through some of the specifics here. But included in the RFP was identifying and requiring MCOs to identify and address factors that impact health to improve health outcomes, so those health-related social needs, enhancing timeliness and accountability around non-emergency medical transportation. So looking at that transportation piece, improving access to interpretation services, reducing healthcare disparities overall, and requiring MCOs to invest a portion of their profits in local communities to improve health outcomes. So we'll hear from MCOs later on how they're addressing some of those issues. Some other key elements that ended up being included in the contracts required managed care organizations to develop a process for identifying social determinants of health, like safe housing, food security, and transportation. So we'll talk about the screening process that MCOs use for identifying those social determinants of health needs or health-related social needs. Also required a holistic integrated care coordination approach, including social determinants of health needs, including those needs and plans of service for the members' goals and service needs. And it also allows for value-based purchasing, which was one of the flexibilities that I mentioned before that CMS provides. Um, so arrangements that must be approved by the state, and they may address health-related social needs, but they also may address other areas as well. Now we're going to take a little bit of a deeper dive into a couple of ways that are explicitly outlined in the contracts. MCOs can provide value-added benefits and in lieu of services, and these are different ways that they can address health-related social needs. So VABs, or value-added benefits, offer optional state-approved benefits not covered under the Kansas Medicaid plan, but are provided by MCOs. So MCOs can offer these services, and they provide payment for those services to improve enrollee health and prevent costly medical interventions. So they aim to enhance the quality of care and support and better health outcomes for Medicaid enrollees. Again, costs are paid by MCOs and can't be passed to the state. The benefits must be available statewide, but they can vary. So MCOs can choose what value-added benefits to offer. Beneficiaries cannot file a grievance or appeal if they're denied a value-added benefit because it's not something the state pays for. And MCOs must outline eligibility requirements, limitations, and the level of provider involvement needed. Here are some of the, from the contracts, we did a thematic analysis, and here are some of the value-added benefits that are offered across all three. Adult dental care, tobacco cessation incentives, pregnancy and postpartum support, so things like doula services, home visits, lactation support, safe sleeping initiatives, and also transportation assistance for pre and postnatal appointments. Also includes behavioral health services for infants, independent living and housing support, so housing and daily activities, job counseling and transition report, so the economic and employment assistance support, and non-medical transportation support as well. So we'll hear from our panelists a little bit later on, the specifics around some of those initiatives and program and how they're addressing these particular topics. Next, we'll talk about in lieu of services. It refers to alternative healthcare services provided by Medicaid managed care plans. They must be offered statewide and must be medically appropriate, cost-effective alternatives to traditional Medicaid services such as inpatient or institutional care. They're designed to improve health outcomes while reducing overall healthcare expenditures. So they can offer these alternative services if they're cost effective and medically appropriate. So MCOs, if they want to offer it, they have to um, obtain approval. So the state has an approved list of alternative services that includes psychiatric care, provide medical supplies, nutrition therapy, home care, telehealth, housing support, and community participation aids. But as any new services that they want to provide that are not on that approved list, as I just mentioned, require a little bit more analysis and state approval. Members cannot be required to use them, and the approved services that are on the list may factor into rate setting unless prohibited by federal law. So here are some in lieu of services that are on the approved list, a little bit more information about those. Behavioral health alternatives can include inpatient psychiatric care, mobile crisis response, community-based stabilization services, and peer-led crisis respite programs to prevent unnecessary hospitalization. Also includes substance use disorder treatments, medically necessary ones, including intensive outpatient programs and withdrawal management services in community-based settings. This could also include coaching, peer support, and wraparound services for individuals experiencing substance use disorders. It does provide for housing support that's approved, temporary housing assistance for individuals transitioning from institutional or inpatient settings. Other in lieu of services approved are hospital diversion programs and enhanced home and community-based services, so in-home behavioral health support, intensive case management, and wraparound care. And plans must ensure, as I mentioned before, cost effectiveness and maintain equivalent or improved health outcomes if they're alternative to a traditional service that's covered by Medicaid. So that was a quick overview of some of the ways that KanCare addresses health-related social needs, and I'm anxious to hear from our panelists, but I did want to note that so all of these things are required and they're outlined in the contracts, but how are they measuring success? How are they measuring progress and whether or not they're complying with some of these requirements? They do include some measures. Um, to ensure that they're meeting state and federal requirements and standards. MCOs must report monthly on various indicators associated with the in lieu of services and also report on the utilization by member population type of the MCOs benefits that are offered beyond the state plan services. So those value added benefits as well. And there are other measures and requirements associated with care coordination specifically that includes some of those items that I mentioned before, like wraparound services or services that address health-related social needs. And so we'll provide more information on that as well. And then another resource that I wanted to mention that will be included in the resource guide after the convening and also here is that KHI supports the KanCare Meaningful Measures Collaborative, and it's a collaborative made up of individuals from state agencies, academic institutions, and other stakeholder groups. And they developed a recommendation for data collection on indicators related to social determinants of health. So we'll also make that available to you all to take a look at as well. And we'll hear more from our panelists about how they measure progress and what success looks like for them related to health-related social needs. Okay, so now I wanted to transition, unless the team has any questions they want to highlight from the presentation or anything we want to address, we can go ahead and transition to our conversation with the MCOs about health-related social needs. Okay, well, let's go ahead and get started. Well, first, I just wanted to kind of ask both of you to introduce yourselves and tell us a little bit about your role and uh, background. Oh, hi, Stephanie. How are you? Stephanie's with United Healthcare as well. So I'll go ahead and turn it over to Healthy Blue first, and then we'll switch over to United Healthcare and we can get going.
Sure. Thanks, Sheena. Thanks, everyone at KHI and KHE for allowing me to be here today. My name is Thamra Subramanian. I'm the Health Equity Director for Healthy Blue Kansas. And so my job is primarily to oversee Healthy Blue's health equity and cultural competency strategy that essentially looks at all of our Medicaid's whole health needs. So how can we reduce disparities and be more equitable across physical health, behavioral health, rural health, maternal child health, social determinants of health. So very excited to be here today. I have a background in public health, and studying social determinants of health was my area of expertise when I was in school. And I was once a community health worker right after college, and really just appreciate this is kind of just my personal passion. I am blessed and privileged to be able to do this work and disrupt the Medicaid space in the ways that I can. And for me, it's important that everyone has the equal opportunity to thrive in this world. My grandma was on Medicaid. She grew up with me in Kansas. I was born in Kansas, and my parents immigrated here from India. So it's very near and dear to me to provide these services to folks and make sure that people have food, housing, shelter, the things they need so that they can actually care about their health. I think there's so many things that need to come first before we can empower folks in the way that they want to be empowered. So happy to be here. I'll pass to Lucia. I'll continue to blab otherwise. So.
Thank you, Tamara. Hi, everyone. It is great to be here with all of you today. And it seems like it's the beginning of the spring, so that makes it extra special. The only bad part is that the moment you say that we were going to start talking, my little chihuahua started barking and asking me to get out. I was like, no, not right now. I hope you don't need to come back, because he's now outside. So I'm a registered nurse. I actually am an immigrant. I come from South America. I moved here when I was about 20 years old to learn English and end up staying. My background is I was a clinical nurse for a long time. I work as a trauma emergency room nurse here in a local hospital. Then around 2013, after doing a lot of volunteer work in community and being in, closely, especially in the Wyandotte area, I decided to leave the clinical work and move into the nonprofit. So I work for a local nonprofit for about 6 years, doing a lot of SDOH, community health workers, maternal, working with the refugees, and I truly, truly loved it. Then in 2019, United Healthcare reached out to me to see if I wanted to join their team to help them design their social determinants of health strategies, and I did. So after that, more and more work came along. Now I also focus on maternal strategies. I oversee some of the cultural competency work that we do on health equity and population health, and that's kind of my story in short. I also have a master in education, but I don't do much with that. I'm too busy with what I'm already doing here. So yeah, that's me. Stephanie?
Jurgensen. I am a nurse as well. My background is in the maternal and child space, primarily in the newborn intensive care unit, and then in different maternal child spaces throughout Kansas City. I grew up in the Dakotas, not Kansas. My mom was one of 7 kids in a town of 70. So I very much appreciate and was raised to appreciate the rural health space and the underserved communities and the Native American space because I'm from the Dakotas. So that is where my passion started, and all of the women in my family actually work in that space now. And then I came over here to United Healthcare and worked in some different roles in the maternity population and the quality team, and have recently transitioned a bit to support Lucia more, not only in the maternity population, but in all of our community programs, as the new RFP has asked for us to collaborate more with communities and stuff. So I'm helping support Lucia in those.
Thank you so much. So I think as everyone can hear, we have a wealth of experience and knowledge and passion and care for the work. And so I kind of wanted to begin our discussion
Sheena,
with, yes,
I think we're missing Angela.
Angela will be in our
Oh, I'm sorry.
next panel. No
Okay.
problem. Thank you.
Sorry.
Keeping
Okay.
me on my
No.
toes.
Yeah. Sorry about
You're
that.
no problem. Yes. We'll definitely get to her after our discussion, and hopefully she can join in. We'll bring y'all back together to discuss any synergies. But yeah, so we discussed a little bit about the recent guidance that has come from the Centers for Medicaid, Medicare and Medicaid Services. So before digging in a little bit, I wanted to ask you all, the federal and state policy landscape is evolving at a rapid pace, especially at the federal level. So with the new guidance that came out, can you talk a little bit about how either this guidance or just the changing landscape in general has been impacting your work and beneficiaries as it relates to health-related social needs?
Sure. Do you want us to go in order, or is whoever start talking?
I think just jump in if you want to respond, and we can see how it goes.
Yes. So, when we were talking about this yesterday, a few days ago, we talked about the implications that it may have at a personal level, and then the implications it may have as a business. So I think it's clear that most of us that work in the Medicaid arena or have historically worked to support underserved communities have our own emotions and thoughts about what is happening, with the dynamics of new policies. And also it's changing very fast, and sometimes we don't even know what is happening. Now, as a large company that serves Medicaid members, that works at a federal and state level, we have to kind of pause when all of this noise is happening and actually try to understand how are these new policies affecting us today, and what is also the long-term effect of some of this, if they maintain over time, of course. So currently, some of these new changes are not going to affect us today. So the way that that Medicaid is framed, the contract that is in place, the waivers that are in place are not going to disappear with the new policies. They are here, and they're going to stay. So we're going to continue the work as it is. Now, that doesn't mean that in the near future, in a few years, when it's time to renew waivers, for example, the 1115 waiver, that things may change. So again, at a personal level, some concerns, anxiety and tension, but also feeling safe on the fact that some of these changes are not impacting our members, at least through the MCO work right now. Yeah.
Thank you
Yeah,
very
I
much.
just wanted to affirm Lucia on that same kind of, I echo similar sentiments. The reality for me, and I guess for us, is more than 80% of our health outcomes in the state of Kansas, anywhere really, can be attributed to these health-related social needs. So our food, housing, employment, community connectedness, transportation, just to name a few. And these health inequities, so barriers to these health-related social needs, will continue to persist in Kansas. And there's plenty of research about that. KHI does a bunch of research on this as well. And as a managed care partner in the state, Healthy Blue, and I know United and all the other MCOs, we're going to follow the state's guidelines and our KanCare contract, which specifically, as Sheena shared, they added health-related social needs, social determinants of health, reducing health disparities, and improving culturally competent care as a contractual requirement for us to uphold. So we will be continuing to uphold that by providing all the services that we're going to be sharing in the next couple of minutes. But we'll continue to monitor and follow the course. But if I take off my MCO hat now, as a public health professional, I think personally, we need to, as a public health community, take more precautions to continue to show our stakeholders, show the state government, the state of Kansas, our community partners, our legislators, the value of addressing these health-related social needs, such as gathering information on the reduction of cost of care for a member. So one of our goals at Healthy Blue this year is really to continuously monitor the financial and quality impacts of our SDOH program. So, for example, how ER readmission rates may be reduced for members who have utilized our housing stability program, or how has postpartum depression rates decreased or stayed the same for members who have utilized our maternal health value-added benefits. These are the types of things that I think as a community we can collaborate more on to make sure it is so crystal clear that there would be no reason to question why this is such an important part of the Medicaid health system. So that's kind of where Healthy Blue stands on here. Similar, we're going to stay the course, follow these guidelines, and also be vigilant. Make sure that these things don't go away, because we all know from either personal experience, members we have talked to, that these programs, these services are valuable. That's why they've been added to the contract. So we want to make sure to continue to be vigilant about tracking our impact and showing that, and also making sure that our members, gathering that feedback from our members as well.
Thank you for very thoughtful responses. And I would encourage the participants to share any particular impacts they're seeing or they're experiencing in their work, or anything related to health-related social needs that they want to share as well, given some federal guidance. And so please share that in the chat. Thank you so much. Okay. Thank you. I think now we can kind of dive into what you all are offering. So can you talk a little bit about how your MCOs are addressing the unique social needs of Kansans, what those might be, any innovations that you're experiencing, and overall, like, how do you identify Medicaid members for addressing health-related social needs? So a little bit about your screening process and any unique services that you're offering that you want to share.
Want to go first? Go first. So as you mentioned, Gina, in the presentation, kind of like the Medicaid population, we can see that is divided on those that are actually heavily managed because have complex needs, and those that are part of the Medicaid population, but we don't manage, just match, which are our kind of like our healthy members. The state, when thinking about screening identifying needs, every Medicaid member, all the MCOs, we universally screen members through what is called the HSD, a health screening tool that contains SDOH questions. So the state did some great improvements to the tool and also to the points that lead to case management. So I don't want to get on the nitty-gritty, but when a member is screened, if the member identifies if an SDOH need is identified, the member is referred to case management. Now, so those members that are case managed, so they're going to have further encounters with the MCO, they're going to be coordinated, they will have further assessments. So that is one venue. Now, not every Medicaid member answers that health screening survey, okay? So many members we are not going to be able to reach. There are other ways that at least we have in place to identify members. When a member calls member service, our member service is trained to ask social determinants of health questions and connect members to resources right on that call through a process that is called social determinants of health real-time offer. So when a member has a need, it needs to be addressed right on that call. Through that process, also members identify for case management. Members can access social determinants of health supports and the health screening tool through the member portal. So let me say, I just don't want to go too big, but members that we are able to connect with will be screening for social determinants of health, and members can also access some of those screening tools through our platforms and app. Then once a member is identified having social needs, there is different ways, and I don't want to take all the time away from Tamara, but we have our bi-directional closed-loop referral system, which is Find Help. Different plans use different platforms. The most popular are the Find Help or United. United uses Find Help. And then we have our internal social determinants of health team and strategy. So I oversee a team of a housing specialist, which has been around forever. Stephanie Klein, everyone knows her because she has been doing housing for about 15 years. We have a food specialist, Celia Ruiz, who focuses on our internal programs and also working with external partners. And then we have an employment and education specialist who runs our employment strategies and also provides supports with a lot of the value-added benefits. I don't know how far you want me to go, but if you want to hear about what that SDOH supports look like, it's pretty robust and nice. And we have multiple programs to support housing, employment and education, and food access, which are a lot of that is supported also through the value-added benefits. I'm going to pause and allow Tamara to share about her before I talk about innovation, because I don't want to take all the time away. Do you think that, Sheena, that's a good idea? Okay.
Yeah, sure. We can just kind of see how it
Let's go
goes.
back
Yeah.
and forth so I don't take all the time away. Yeah, go ahead, Tamara.
So much of our process is very similar to what Lucia shared. I would say one key difference that we worked on during our implementation. So as many of you know, Healthy Blues and You managed care organization, we just went live in January. So that's my little caveat there. And because of that, we had an opportunity to kind of revamp some of our processes internally. So as Lucia said, many KanCare members have a care coordinator assigned to them based off of their risk level, and many don't. But we're looking at the whole Medicaid population, which to be qualified for Medicaid, the circumstances that your life has, you're more than likely to also have some type of health-related social need. And that's the reality of it. So something that my team worked on the back end was how can we more quickly assess social determinants of health needs and put less of the burden on the member to have to outreach or a case manager to have to outreach. And then for the majority of our members who don't have a case manager, the only way they can really access our resources is if they reached out per se, or if their provider referred them. And so we were thinking, what's a way, since we do have to address by KanCare contract in the first 90 days, we need to talk to a member, have a member interaction, and share that health screen if we can, which, as Lucia said, not everyone wants to take a screen, but to each their own. So what we did is we added the PREPARE assessment, which is PREPARE is an acronym for something very long. It's an SDOH tool. It's about 20 questions that ask about various social health needs. We integrated that into the state screen so that when a member is called and takes the state screen, or if a member is on their member app that we use, they can take the state screen and the 20 questions are at the end. And we configured our systems internally so that if a member says or designates they have a food, housing, employment, utility need, or if they feel unsafe in their home, it triggers an automatic referral to our social determinants of health team. So similar to United, we have 2 housing specialists, 2 employment specialists, one focused on the LTSS community and one that's non-LTSS. We also have a 3 social resource team call center community health workers who can address any other non-housing and employment need. And we also have 15 on in-field social community health workers, so all across the state. So when that automatic referral gets sent to the social determinants of health team in our care management platform, that social determinant health of team member actively reaches out to our member being like, hey, I saw that you had a food need. Are you interested in learning more? And then on that call, we're able to automatically connect them to resources in our community. We also use Find Help, as Lucia said, or we connect them to value-added benefits that we offer, or we connect them to our internal housing and employment programs. So there's a slew of options, but the really great thing about how we've started it is we've gotten over, I would say, 1,500 to 2,000 people who've actively taken the optional prepare questions, which is just wild to me because as someone, like if someone gave me a survey, like not a great chance that I'm going to do it unless there's an incentive to it. But what's really awesome is people actually want these resources or are interested about them. Sometimes they just don't know how to go about it. And this is a great way where they just have to fill out the survey and something actually happens and they don't have to do it, which has been really successful for us so far. So within the last 2 months, about 2,000 people have filled out the survey and we've had about 1,500, so 75% of them screen positive for one of those social health needs that were listed, at least one. And so really awesome. And our team is really dedicated to getting people what they need. And it's also been a big flag to us and an aha that there's so many people with complex social determinants of health needs. So we're working with our care management team to see how we can increase the complex SDOH care coordination and what that looks like. So yeah, that's how we screen. Other than the screen, a provider can refer members. Members can call into our member services and access our social resource team. And we also have a value-based program for providers where they can also connect members on Find Help and get a payment for closing the loop on a community resource, meaning they're following through with the member to see if they actually access that resource. So a handful of different ways, but we're finding a lot of success in kind of automating and making the process a little bit more efficient for our members.
Thank you. So much information that I think is really helpful for people to understand the process and that it is available to more than just, a few members. It is available to all members. So thank you so much. I did want to lift up a couple of questions that we've been getting in our Q&A or the chat. And it's around kind of thinking about the cost of living, thinking about the income limits and eligibility limits in Kansas being lower. Um, how are how have you all approached collaborating either with state agencies or organizations or others, especially if they're receiving services in other ways, to kind of address some of the ongoing, maybe broader, environment, either political environment or the economic, more so the economic environment that all Kansans are really living in at the moment.
You,
Or
yeah,
go
go
ahead,
ahead.
Lucia.
No,
Oh.
go ahead.
I was just going to say, I mean, if you're like, since we're new, we're still growing and strengthening our community partnerships. But something we've been trying to do is really focus on like quality over quantity of community partnerships that people we've already heard from our members they leverage. And something we're doing to strengthen our partnerships is a program where we sign a contract and actually pay these community partners to help us follow through with our members on resources. So if we refer them to a food pantry, And that food pantry has a contract with us, and they give that member food. We will then provide a small incentive payment for every kind of follow through that they have. And that's been pretty successful so far, and we're still looking for more partners who want to be part of that. But at the end of the day, like, we want to make sure we're not duplicating efforts that are already happening in the community. There's so much great stuff that local health departments are doing, CBOs are doing. And at the end of the day, say something happens in the state government where we cannot provide social resources anymore directly as an MCO. I'm just saying that out of like the worst thing that could happen per se. We want to make sure we have these strong relationships with community partners so that we can kind of pass the torch to them and still provide the care and services that our members need. So I don't know if that particularly answered your question, but community partnerships, local health departments, they're all super important, and we just started, so we're still exploring and meeting people in this space. And we know there's so much great work going on, but making sure that our data systems also talk to each other is really important as well in that.
I think
Well, thank you.
Sorry, I was just going to add on. I think understanding that while the changing environment we're seeing regularly is affecting us as a Medicaid system, it's also affecting a lot of our community partners as well. And so trying to help support our members through maybe some loss of those community resources as they are affected by different funding and grant rules and things like that. Figuring out how to close those gaps as they come has made our job more interesting in the last few months of, knowing what's still available and kind of easing some of the concerns that people may have, or understanding what are valid concerns. The unwinding of Medicaid was a stressful time. I mean, as not being new providers, people had Medicaid throughout the entire state of the emergency. And so helping them, even if they were maybe ineligible with us, staying with them for a few more weeks and helping them identify a way to find some sort of coverage. We try to support them and help them transition if that has occurred as well.
That's a great example. I guess I also would like to add, historically we have had, our main focus has been employment and education, and we have worked closely with our workforce partnership partners around the state, the 4 areas that we have, focusing also on housing, which I think I saw something on the chat about housing, which is, I think, one of our biggest barriers, right? We had some robust programs in place until the CMS policy passed in 2024, and then no Medicaid funds could be used for housing, and that really kind of limit our capacity to maintain those programs. Now we're currently working with some of our housing partners and with the hope of providing funds to help with the care coordination. So we do have our own housing navigator and care coordination, but our housing partners have realized the need of having more individuals. The volume is bigger, right? And the resources seems to be smaller. So I think that, Gina, I think that part of what is being asked on the chat is how do we work with the state with these large issues? And I think that takes a lot of the communication, having, the message, and that goes back to Stephanie, the example you were sharing about what happened, after the emergency. Oh my God, my English is dying, or my brain is just dying. When the public health emergency went away, what was the information that we needed to provide to members? And we're very closely with the state to provide that information and make sure that our members and anyone in community knew that this was happening and what they needed to do to maintain coverage. So it was stressful, but we were working together to make it happen. So I don't know if I answered the question, but it's having the close communication, being aware of the large and strong partners we do have in community, which in this case, as my colleagues mentioned, some of them are already suffering what is happening at a political level, and the lack of resources coming down the pipe, which is very concerning. Yeah.
Thank you so much. That's helpful. And I think we had a couple of other questions that are related to that. So thinking through before when you were talking about screening, there was a question, and you can either just quickly address it or address it in chat too, but how could community health workers that are also providing Medicaid enrollment services best share the screening results with the MCO, with the consumer's MCO? And how is there currently a process for that, or would you prefer them to also take your specified screening?
So yeah, I don't, maybe, based on what Tamara shared, the Blues may have something in place. We don't have currently any community health worker that is not United have access to our systems or anything on that level. There has been conversations, and we had conversations with the state about allowing no MCO employees complete screenings for us, but that it has not yet moved forward. We do have close relationship with the community health workers in community and with clinical partners, but no, that's an area that in our side that needs improvement. But there is a lot of processes in place to protect member information. And so again, the typical barriers that we all know about are still present. So it's going to, I think at one point it will happen. And I think the state is aiming for that, but we are not there yet.
Yeah, I wish that you all could use your screen and then give it to us and all is dandy and well. I would say right now, the best solution would be like, please reach out to us and make sure that we are giving the member our screener, if that makes sense. Or if you identified a social health need for that member, even providing us that member name and ID if they're part of our MCO. And then our team can follow up. That is something that we could do. I know there's not a really formal process yet, but I would love to kind of continue that conversation and see if there's a workaround we can do. Because for our state quality measures, we have to use the screener that we use, and inputting in data. That's why I was saying, like, the data systems for everyone needs to kind of interact in the state. It does not, which I'm pretty new to the managed care space. And the data systems are just like chaos. It's like a neighborhood full of different colored houses, some townhouses, some apartments. Some have a garage, some have no garage. That's basically how it is. There's not a lot of standardization. But something that our quality director is working on is maybe a pilot with local health departments to see how we can maybe share our electronic medical system with them for 6 months and see what kind of synergies can we make, what health information exchange can we do. So that's something that's in progress that we're exploring, and we're trying to explore early so that, because it'll take time to do that kind of data transfer and sharing. But it's a great point. So yeah, if you guys do have members who are enrolled Tele Blue or United or anyone, just please reach out to us if you know they have a social need, and we can definitely get them connected. That is not an issue at all. We just don't know what we don't know. So your help is the best.
And Tamara, to your point, I think that also is something on the chat that we're talking about people that are being reached out by multiple individuals, right? Mm-hmm. So there is this balance of the things that we must do as an MCO. Then we really put a lot of effort on referring members and connecting them with community-based programs. First, because we value their work. Second, because the state wants us to do so. And also because those programs have asked us for referrals. So what I wanted to say with that is at times we may not be able to share our screenings. That takes a higher level of security and stuff like that. But we do make an effort to connect our members, and we have like direct relationships like the health departments. We do send them a list of members that may qualify for the programs for them to reach out to them. It doesn't happen with all health departments. Some health departments don't have capacity, but the health departments that have asked for that. That is in place. We also use, although we use Find Help, we also use IRIS for our maternal and child programs. So we have that bidirectional referral in which we send our moms, we try to connect them to community-based programs that support moms and kids. And in that process, we have very close communication with the home visitors through that IRIS platform, which is an amazing, I love IRIS. So I think we do have a lot of these partnerships in place, which is, as we all know, there is no integration of our systems. And I don't know when that really is ever going to happen, just because of the high level of security that all these systems need because of the protection of the member and the information. Yeah.
Thank you so much. Well, I love hearing perspectives and how maybe potential collaborations and improvements could be discussed and moving forward. And that's part of why we convene discussions like this. So very, very interesting to hear about the processes, both opportunities and challenges. And I think we just have a couple more minutes. So I wanted to give just kind of a couple of more notes to hear from. Are there any innovations or strategies or best practices that you're using that you offer to members that you want to highlight? And in addition, thinking about that community piece as you consider working with communities and how you work with communities, there was a requirement in the contract to kind of reinvest into communities. And so how are you you all, your MCOs approaching that? And any kind of, you know, are there any strategies or innovations aside from what you've already mentioned related to community collaboration or investment that you want to mention before we close?
I can go very fast. I think that's of innovation. I would like to mention a couple. We do have something that is called Dr. Chat. Maybe you guys know it. Is virtual care, and it's, I think, very important for our members in rural areas. And the goal of this is to provide care in a timely manner, and also so improve access, and also the proper use of healthcare services. So this is a tool that allows members to chat and have a virtual encounter with a doctor for things that are like urgent care. Doctors in their process do a screen for SDOH and connect to resources. That will be one thing that I really love. I think we really love it. Our members really love it. And other things, I like to switch to maternity because it's my area and our area with Stephanie. We have one of our value-added benefits is actually nutritional support for our high-risk pregnancies. So we have a partnership with Attain. Used to be food market. Oh my God. It had a previous name. The name now is Attain. Sorry, forgot that. The Free From Market. Sorry. So we provide 4 months of nutritional support. Our members go into a website and they purchase their own food, which is really important for, to support members' choice. That is for our high-risk pregnancies. And then you ask community investment. So community investment, which is part of the contract, will not launch until 2024. So we historically have had partnerships with multiple community partners, including housing investments, work with employment partners. Some of the things that we have in place for this year, I believe that fall under that is investment on a maternal community-based program. We provided some funds to a couple of COCs, the Continuum of Care housing partners. We also have a partnership to support members exiting the correctional system and some other things. But those are not count under the community investment just because that will not launch until 2026.
I can go real quick with mine as well. As Sheena shared before, on the in lieu of services benefits, a lot of the housing coverage is only for folks on certain waivers. So we realize that that's a huge need and gap area. So we launched this past January a housing program that works with members who they may not be fully homeless yet, but maybe at risk of homelessness, or perhaps they had housing and they're going to be kicked out soon or feel like they might be evicted, or they feel unsafe in their home, like there may be some violence or something. So because of that, we launched a program where all members are technically eligible, LTSS, non-LTSS, and we connect them to our organization, an organization called Upside, and they call them within 5 minutes of us referring them to them, which is awesome. So in less than 5 minutes, you're going to get a phone call from someone else who's like, hey, what are your needs? And they basically work as almost like a housing care coordinator per se, with the member to connect them to what's within their community. Sometimes they can find someone face to face for them to work with, guide them to any housing that's open in the area, as well as any other social needs such as food and shelter. And they have access to all of our other SDOH programs. So that's been really successful so far. And it also allows us in our communities. And on that note, too, we helped the Balance of State Continuum of Care, as well as the Sedgwick County Housing Coalition, fund a program called Pad Mission, which is basically Zillow for affordable housing. And so that is something that they're working on, kind of creating a database for folks to be like, hey, where's affordable housing in my area? Where are some places that can take Section 8 waivers, things like that. Yes, it's kind of like Zillow, but for affordable housing. So those are just a few things we have in store for our members. And then lastly, I just wanted to also plug the doula coverage by KanCare that started in July, has been really wonderful, and something we really want to leverage and build out as a new MCO. Something we're doing because we've noticed just a lack of doulas in rural areas and a lack of doulas of color is we've been working with Kansas Birth Justice Society to help sponsor some of their trainings. Their trainings are specific to people of color, rural areas. And so we're working with them closely to not only fund more trainings to get more doulas trained into being a doula, but also to connect doulas to Healthy Blue and understanding the Kansas KHI contracting process. Since it's new, it can be kind of confusing, and all of our MCOs have the same kind of process with the state. So working with them to just develop an open communication so we can directly hear doulas' concerns about logistics, billing, things like that. So that's something in the works that we're really excited about, and I hope to hear more about on our next webinar. So that'll be great.
Yes, thank you so much. Well, thank you. I know that there are many more questions, and we're receiving questions, lots of engaged folks present. And so if we didn't get a chance to answer your question, we'll make every effort to follow up with the appropriate person that can answer your question, and we can include it in the event recap. Once again, just express my sincere appreciation for your work and your participation in today's panel and being willing to, answer any questions related to health-related social needs and beyond. So thank you so much to our panelists. I'm going to go ahead now and switch it back over to my colleague, Emma Urich, who will lead our conversation with hearing from the community perspective, with our next panelist. So I'll turn it over to you, Emma, to introduce yourself and the next phase of our convening. Thanks so much.
Thank you so much, Sheena. And yeah, we're 8 minutes past 2 o'clock and still have 86 folks online. So thanks for hanging on with us because we have another great panel discussion with our speaker, Angela Scott. But first, my name is Emma Urich. I'm an analyst at the Kansas Health Institute, and I work very closely with Sheena on access to care projects at KHI and related research. So it's great working with her, and it's great having these wonderful conversations that we're having like today. So I'm going to then switch it over for our panelist to introduce herself, Angela Scott. We are so grateful to have her here today. And Angela, I will turn it over to you to tell us a bit about yourself and your work.
Great. Thank you, Emma. Good afternoon, everyone. I'm Angela Scott, and I'm with Communities Organizing to Promote Equity. It is a program through the University of Kansas Medical Center. I am the field CHW field supervisor. I also work with the program manager, Ton Maris, and our role with this project is to hire and train community health workers across the state of Kansas. This project was very exciting because it allowed us to be able to serve our communities in a way that was very thoughtful, taking our communities' thoughts and perspectives in mind. And so our project, it had two arms to it. But I'll tell you a little bit more about my background before I go into that. So I am a community health worker as well. I've been in this similar profession for quite a while. I remember graduating out of, or leaving high school, going into the helping field and deciding, just based on my experience as a child and being raised in a single parent home and remembering some of the challenges, that I would see growing up and, some of the resources that my family had to access. And so naturally it was, for me to go into more of the social service field or the helping field, because I truly enjoyed being able to see my family thrive, even at a young age, because of the support we were able to get from members of our community. And so I've worked in positions such as working with Head Start as case manager or a family support worker. Also had experience in working with managed care organizations. And actually before the managed care organizations came on the scene, I was a case manager working with waiver services, the HCBS waiver services. So again, just a natural progression for me to get into being a community health worker. And so I became a community health worker supervisor back in, it's probably been about 8 years ago. I was working for a federally qualified health center in Kansas City. I had a team of community health workers that I was supervising at our clinic, but then also we had community health workers that were also boots on the ground in our communities and having those conversations, again, with community members, finding out what their needs were, and then how can we help and assist to make sure that their needs were being met, not only medically, but also socially, most important. So for our project, Communities Organizing to Promote Equity, we have two arms to this project. We had our community health workers, and we also had local health equity action teams in each of our communities. As I mentioned, this project was really large because we were in 20 counties across Kansas. We were very intentional about going into our communities. We started out, most of our team is in Kansas City. I live in Wichita, but we were very intentional about going into those communities and making sure we're hiring regional managers for each of those communities, making sure we're hiring community health workers who were those lived experienced community members to be able to help us with this project. And it took quite a while to hire. We hired over 54 community health workers across the state of Kansas. Again, being very intentional about hiring community health workers who were familiar with the needs of the community, who already were rock stars in their community. Community health workers are people who are trusted members of the community. So that was another important piece of that. And so going through that process, we learned a lot from our communities, and I feel like we did really well. Our project, and it was started out to be a 2-year program. We were able to get a no-cost extension and ended up being 3 years. And so we were very excited to really do some great work in the communities with those folks, the boots on the ground folks, making sure that our communities had what they needed to be successful. And I can share, do you want me to go ahead and go into a little bit of outcomes from our project, or did you have any
I
other
will
questions
flag.
first?
So
Okay.
so in the chat, Lindsay, my colleague, has dropped several resources. So you gave a great high level description about who CHWs are, the types of work they do, where they're found throughout the state. They could be working in that community health clinic setting, or they're in health departments and other locations. I know a lot of folks in chat may also be currently serving in a role as a CHW as well. So I just wanted to highlight some of those resources for folks who may be just learning about the community health profession. I know I first ran into this profession in undergrad when I received my community health education bachelor's, and it looks different. And CHWs live in several different areas and also different settings where they work.
Yeah, absolutely. So we had community health workers in our urban areas such as Wyandotte County, Johnson County, Sedgwick County. But then again, we were also in Seward and Grant County, some of our northwest counties where it was more rural. So yeah, and so we had community health workers in various different organizations. As you mentioned, we're in clinics. We partner with community-based organizations, health departments, just almost anybody you could think of, to be able to, again, to make sure we had a strong workforce of community health workers, but also build a strong local health equity action team, which was comprised of our community health workers, community-based organizations, and most importantly, our community members. So, and Lucia, thank you for your comment. I've done a lot, known Lucia for quite a while, and United Healthcare has been very instrumental in supporting COPE, and so we really appreciate it. United Healthcare. Also, Aetna did a lot of work with us, and definitely look forward to working with Health Blue, our new MCO. So.
No, yeah, that's great. And I think your collaboration and partnership with the managed care organizations is really great. And I think, learning about how CHWs interact with Medicaid members and beneficiaries is something I think we'd love to know more about. So can you just tell us a bit more about maybe some CHW activities in supporting Medicaid members and
Sure.
maybe even how many are served? So clients that CHWs work with, how many are actually on Medicaid or other insurance types?
Okay, sure. So overall, our project, we served 5,144 community members across those 22 counties. And out of that number, we had 900 clients that were served. They reported having Medicaid or Medicare benefits. There was some information. We were sure that some of those numbers were higher, but asking the insurance question, if they declined to answer, they didn't have to do that. And so some information we may not have had. But we did have several of our community members. So as I mentioned, we had over 900 clients reporting having Medicaid or other benefits such as Medicare. And so as a community health workers, it was really important that we built those personal relationships with the MCOs because we were going to be working with their members. So just for example, if we received a referral from a community member and they had one of the MCOs as their insurance, but they were really unsure about how to access their benefits. Our community health workers had to be really knowledgeable about, every single community managed care company so that we could support that community member. And so being familiar with the added value benefits or just the benefits overall, a community health worker would be able to walk through the process and talk about, so what is the need? Do we need to contact your MCO? If it's transportation, you're missing doctor's appointments, and we know that your MCO may be able to help you with that transportation. Would you like to make that call together? Or is it that you just need to get the phone number and you're able to do that on your own? And one of the things our community health workers would do, not only would we make that phone call with them, if it takes coming out to the house to have that conversation and make that phone call, or meeting them somewhere in the community, we were able to do that. And then again, make sure they were able to navigate getting in contact with someone from the MCO, making sure that they understood what the benefits were. And then also talking about if they had any other needs that the community health worker could assist with. When we work with our community members, we have a needs assessment that we complete. For our particular project, there were 18 domains that we assessed. Some of those were mentioned by the MCOs, such as do they have transportation, if their housing needs, food needs. One of the questions we do ask is if they have insurance. And if we find they do not, and we are knowledgeable about what the qualifications are for Medicaid, we would assist and walk through completing an application with the community member.
Yeah, no, that's great to hear. And I know in chat earlier, folks want to know like how CHWs assist families in accessing all those amazing value-added benefits that MCOs offer. And
Mhm.
so what that looks like in practice, you said, they meet the member where they are. They try to do what's best and on a case-by-case basis, what is
Mhm.
best for that client. I guess,
Absolutely.
what are some kind of challenges, but also opportunities community health workers are seeing with that coordination process and just navigating all these different benefits?
Yeah, so some of the challenges we may run into when having access to some benefits, it may be that a member at the time, maybe their phone may be off, so they're not able to make those phone calls. So again, us being able to have ways to have contact outside of if a member does not have a phone call, so that in-person contact is really great. Um, Another challenge that we run into is sometimes they may not qualify for certain benefits, which, can be very challenging, especially if you're someone who is experiencing high blood pressure, or if you have diabetes, or again, you're experiencing lack of resources in your community. As I mentioned, we work in rural areas. Maybe somebody does have KanCare and they need medical care, but in their community, there's no rural hospital, there are no providers. And so they're having to travel to Wichita or to Kansas City to receive that care. But also, if there is if they're under resourced in the area, transportation, how do they get to those appointments that are further out? Because that may mean if they're driving to Kansas City, that's a 6 hour plus drive for someone. So they probably would need lodging and those different types of things like that. So we really try and work through every aspect, every step with that community member to make sure that they get connected or find other avenues to make sure that they get the care that they need.
Yeah, there's definitely a lot of logistics, especially when you're
Yeah.
talking about traveling across, county lines, hours away for your
Mhm.
appointment. And I know there was mention of transportation issues with
Mhm.
Medicaid transportation providers. I know many rural and frontier counties of the state may only have one transportation provider, and there's some limitations with traveling outside different regions of the state and counties. So it's definitely a consideration for future discussion on Medicaid. And but I think so. We only have about 10 minutes left of
Okay.
our conversation. And so I think we can look ahead to the future. And I think
Mm.
integrating CHWs, it emerged as a priority area for MCOs and the KanCare program. But what kind of challenges do CHWs face broadly in Kansas when they're
Mhm.
working with Medicaid, um,
Okay.
specifically?
Yeah, so I'll mention this as well. In Kansas, we have the Kansas Coalition for Community Health Workers, and I'm the co-president for that organization. So that's one of the things that I work on a state level and coming together with other organizations and talking about what are the concerns and the challenges overall. We're fortunate in Kansas to be able to bill for Medicaid, but sustainability is one of the biggest concerns. Whether you're a clinic, whether you're a community-based organization, that is one of the topics that we are having conversations about all the time. And even with the state of Kansas are being able to bill Medicaid. Not every organization qualifies for that. And most of the community health worker programs are grant funded. And so that sustainability piece continues to be a challenge overall. But I am grateful for the partners that we have in Kansas that are willing to come together and talk about, solutions, and not only on our state level, but looking at other states around to see what they're doing and to see what's working, and again just to see how we can implement some things hopefully in Kansas to be able to sustain community health workers. And I'll just say this for an example. Our project I mentioned, we were able to run for 3 years, and we had 50 plus community health workers. One of the things we were very intentional about was partnering with other organizations in those communities and allowing them to become employees of that organization in their community. So hopefully that, there was to be some sustainability. They were no longer with us. And so maybe they could acquire positions within other organizations that they were providing community health worker services for. It still ended up being a challenge because, again, that sustainability piece has been very challenging. So.
Yeah, and it sounds like just the CHW profession, just embedding that role in different community-based organizations, social services will be so important in the coming years. So thank you for sharing that. And so you mentioned other states that are doing some great work in this area, maybe some emerging strategies that we can look to model here in Kansas. Are there any states in particular?
So we've been looking at New Mexico, and then also in Florida, I was able to do a partnership and just see how their training works. So that has been very useful. And then also South Carolina was another state that we looked at what they're doing as far as sustainability, and not only sustainability, but also looking at CHW certification and training. And so that's another thing that the Kansas Coalition works on, as well as, again, when employers are able to come to the table, we want to make sure as we build this workforce and as we get funding and are able to sustain community health workers in our community, we want to make sure that they have the education and certification that they need to be able to provide quality services. And I know there was a comment, and Lucia had mentioned about the education requirement for care coordination and the barriers to CHW integration with MCOs. Okay.
Yeah, is there anything you can elaborate or talk more about? Just maybe the educational requirements that's needed to do care coordination and be able to bill for that service?
Yeah, and I do, and I will share a link that will have more information about the care coordination piece for, especially for community health workers. As I mentioned, we are able to bill for community health worker services. Some services are not billable. Community health workers do a lot of work outside of just meeting with clients, and most of the items we can bill for, it's that direct client interaction thing that's happening. But there are a lot of things that happen behind the scene, the building of the partnerships, the doing the service coordination behind the scenes are some things that may not be billable. But again, is a great large part of the work that community health workers are doing. So going back to certification and the curriculum for community health workers, we do have the Kansas community health worker curriculum. One of the things that we found, it's a great curriculum. We did find that we were struggling and having a challenge with getting people into those courses because we had limited providers. That definitely has improved compared to 3 years ago, and they continue to look at the curriculum and trying to get people through the course by adding additional providers for the course. The other thing is that we also have a reciprocity for becoming a certification for community health workers, which I think is really going to be helpful. Community health workers can receive certification through their work experience, their education pathways for that as well. As well as currently we are looking at, occasionally we have community health workers that come to us from other states, and they may have taken a similar course. If we have a community health worker that comes from New Mexico and they went through that curriculum there, we were able to look at reciprocity instead of having them, okay, now you have to become certified in Kansas, before you can perform work. And that's going to be one of the requirements in order to be able to bill for certain services as well, is that certification as a community health worker.
Oh, thank you so much, Angela. And I want to be mindful of time. And I just want to thank you for talking about the challenges, but also the opportunities for the profession. And I'm seeing the comments in chat of folks, outlining some of the different things they're experiencing in their work and communities and the responsiveness and looking for solutions and problem solving has been really great to see in this session. So I hope everyone also is taking that away with them today and into the rest of their week. So thank you so much. I really appreciate you.
Okay, yes, thank you. I'm going to drop a link in the chat. We have I'll share this. This is a documentary my coworker did about community health workers in our project. It's been shown locally, but also in other countries. But it really just highlights the work that has been done by community health workers in Kansas.
Thank you, Angela. And to close us out, I will take us back to Rebecca, my colleague Rebecca, to leave you all with some really valuable resources.
Thank you, Emma. And thank you everyone for hanging on with us in this last minute. I will be sharing some resources and some information that I think will be of interest to everybody who's on the call. And so again, thank you to Sheena and Emma for facilitating today's session, and a big thank you to all of our speakers today for joining us. Lucia, Stephanie, Thamara, and Angela, we really appreciate your time and your valuable insights.
Thank you.
So yeah, no, it was a pleasure and such a joy to hear from all of you, and an exciting way to kick off this four-part series. As Carrie mentioned at the beginning, this is the first of a four-part series that's happening quarterly throughout the year, and we're excited to continue this conversation on June 10th. So be sure to, if you haven't registered for that one yet, make sure you register. Feel free to share that registration link with your networks as well to anybody who might be interested. And as a quick note, reminder, as Sheena mentioned, if you attend all four sessions, you will receive a special keepsake for your commitment to the series. And then we would also like to ensure that you have access to all the resources mentioned today. And so in the chat, you will find a resource guide, and that's in a PDF format. And in that guide, you'll find a variety of links, just a lot of really great information relating to today's topic, as well as a second page that has a space for you to take notes and jot down your key takeaways and reflections. This can be something that you also use with your organization or team to continue thinking and learning about this topic. So I'll give everyone a moment to grab that PDF in the chat. And then this being kind of the first of its kind, this series, we are trying something new and sort of spacing out the learning throughout the year and offering a quarterly session. We're really interested in your feedback. So if you click on the link in the chat or you can scan this QR code with your phone, you'll find a very brief survey. We'd love to hear your thoughts about the format, the topic, what felt really valuable and meaningful for you. It's that feedback that helps us design sessions that are really meaningful and relevant to you and the work that you're doing out in your community. So we appreciate you sharing your feedback and your thoughts. All right. And with that, thank you so much for joining us for the first session of the KHI Policy Series, Exploring Medicaid in Kansas. We look forward to seeing you on June 10th, and we hope you have a wonderful day.